excited about, and recording is in progress as well. And we would love to have two discussants to discuss this case that Shema has brought with me and with her. Ideally, one volunteer identifying as a woman and one identifying as a man. Do we have any volunteers who'd like to discuss a case this morning? Great. We have one volunteer, Suresh. Thank you. Anyone like to discuss with Suresh? Ideally, someone identifying as a woman for this morning. Anyone? It's a small group today, so I know we'd be asking 10% of you to volunteer as opposed to asking usually 2.5%. Yes, we have a second vol. Fantastic. Wow, this is record time. It's 9:05. We have a case and two volunteers. Wonderful. Maria, I think, is going to be ambidextrously scribing and doing teaching points and typing words of encouragement. So thank you for doing all those things. Shema, Nitya, and Suresh, would you like to introduce yourselves? Tell us where you're joining us from, and then we'll go ahead and get started.
Sure. Hi, my name is Shema, and I'm currently a 50 medical student from Berlin. And I've been participating in CP Solvers since November. It was really a coincidence, and I really enjoy clinical reasoning. I'm so happy to share a case with you all.
Great. Thank you, Shema.
Hello, everyone. I'm Suresh. I'm a third-year med student from India, like the southern part of India. And this is my first time discussing a case. So super excited. Yeah.
Great. Thanks for joining us. And where exactly in India, if you don't mind us asking?
Yeah, from Bangalore, India.
From Bangalore. Fantastic. Great. And Nitya?
Yeah, so nice to meet you both and the clinical problem solvers. I go to med school in Florida. I'm in my second year, and I heard about you guys because I was reading a book. And Suresh, that's so funny. I lived in Bangalore for 7 years before moving back home here. So it's so nice to meet you all.
Wonderful. Well, thanks for joining us. And Deborah has put in the chat, this is the 600th VMR episode. Wow, that is amazing. This started during the early days of the pandemic, not the 600th neurology one, though we will get there eventually. Maria probably knows the exact number. I don't, but it is known. It is somewhere. Fantastic. Well, this is great. Is this your first time then joining us, Nitya, in a morning report, or?
Yes, it is. I'm taking a chance because I took neurology a few months ago.
Fantastic. Well, thanks for taking a chance. And I ask mostly just to, so we can let you know the format here is a morning report style format. So I have no idea anything about the case except that Shema has brought it to us, and she will tell us bits and pieces as we go. And then I'll ask you and Suresh to think through them. And it's fun, safe space, no pressure. And then I'll maybe ask you some questions to, and if you mention something I think would be interesting to talk about further or teach us about, we'll do that. Otherwise, we'll just keep going until we find our way to the end of the case in bits and pieces. So with that in mind, Shema, would you like to give us just the chief concern, chief complaint in as few words as possible, and we'll go ahead and get started.
Yeah, so I decided to divide the case into 5 other quads, and I will start with the chief complaint. The chief complaint is a fine motor impairment of the right hand for 3 years.
Fine motor impairment of the right hand for 3 years. So Nitya, what's coming to mind as you hear these first few words of the case?
Yes, I'm wondering like what exactly the impairment is. Like I'm thinking of, different nerves and their sensory innervation, and I'm trying to think of how to localize if there's a lesion present.
Yeah, great. So the first question we're going to want to figure out is where the lesion is. And so you said you just had your neuro course, no pressure, but for moving the right hand, would you be able to walk us through some of what you know about where potential lesions could be that could impair movements of the right hand? You mentioned the nerves that come to the hand, which is great. Any other place this could be? Obviously, we have very little information so far, but just thinking broadly.
Yeah, thinking broadly. I'm thinking of I think it's the spinothalamic tract, but I'm thinking that since it's the right hand, that the lesion is probably on the left side of the brain. So that's just kind of a very foundational way I'm thinking about it.
Yeah, great. So this could be a lesion in the nerves to the hand, and you made the important point that we're hearing fine motor impairment. Is that due to weakness, or as you mentioned, could that be due to sensory loss? That's just making the person might say my hand is clumsy, but that could be weakness or incoordination even, or it could be a sensory deficit that's making it hard to sort of know where the hand is in space or what's in the hand. And as you said, two possibilities could be the left brain or the right nerves, nerve or nerves to the hand. Great. Suresh, what's coming to mind here after this great start from Nitya? Anything else you'd like to add in terms of what you're thinking at this stage?
Yeah, like the time since 3 years means like I'm thinking of like subacute to chronic type of like disease progression, and as the localized, as in everything in neurology, you can differential is time course times localization. So time course is already given, and localization along from the motor cortex to the tip of the fingers. If anywhere you can sort of find out the lesion. So considering dividing into lesions in the CNS and lesions in the peripheral nervous system. Lesions in the CNS from motor cortex, from subcortical white matter, then your upper motor neurons, then coming down to the spinal cord, you got the roots, the dorsal root ganglion, the peripheral nerves, and then as you said, it could be either like motor, like just weakness, or I guess it can be also a sensory loss as well. And the patient just like he's holding a pen and he just doesn't feel like he's holding the pen strongly enough, like he's holding it hard enough. So that could also be like a complaint, like that he might be complaining, yeah, maybe that I'm feeling weak. So I guess, yeah, differentials are broad. So let's see what Shema has to tell us more.
Yeah, fantastic, Suresh. Great discussion complementing Nitya's discussion. So just to add a few things, and then we'll hear the history, right? So I think broadly speaking, the patient we'll hear what how the patient is describing this, but some problem with the right hand and using the right hand, and we use the hands a lot, right? So even small deficits can make it hard to do the very fine motor types of things we do, typing on our keyboards, typing on our phones, etc. But the patient might say my hand feels weak or my hand feels clumsy, but that could be true weakness, a motor deficit. That could be sensory loss, or that could even be something like ataxia, right? Something in the cerebellar or proprioceptive pathways. So the localization really is very broad because we're not even sure yet which tract we're talking about, and we'll have to hear in the history if the patient perceives weakness. Is there anything to suggest sensory loss? Questions you could ask, when you're washing your hands, can you feel the temperature of the water? And you could ask whether the hand feels clumsy, whether there's numbness, tingling, those sorts of things to get a sense. But if we take motor at face value, since you both sort of started putting the map together for that, we'll just complete it, right? So as Nitya said, if we're in the brain, we'd be on the left side of the brain, right? And we'd be talking about the corticospinal tract, which begins in the precentral gyrus, and the face is most lateral, and the hand is a little more medial, and then the leg is the most medial, and the hand takes up a huge part of that. Remember, the homunculus looks like, when people draw it as a cartoon, right? Big face, big lips, and big hands, because those are areas that are very dexterous in human activities, right? So those hand fibers with the rest of the corticospinal tract would descend in the posterior limb of the internal capsule through the anterior brainstem, cerebral peduncle in the midbrain, basis pontus in the pons, medullary pyramids in the medulla, and then cross at the cervico-medullary junction to then go over to the other side. So what started in the left brain and brainstem is now traversing the right spinal cord on the way down. And if we're talking about the hand, it will synapse on its lower motor neurons in somewhere between, for the arm, we'd say C5 to T1, but for the hand specifically, probably more C7 to T1. Those lower motor neuron cell bodies in the anterior horns would come out to form ventral roots, which would converge to form the brachial plexus, which would then give off multiple nerves to the upper extremity. And for the hand, we'd be most interested in the radial, ulnar, and median nerves, right? So as Suresh said, broadly speaking, we can say, is this an upper motor neuron problem, a brain, brainstem, spinal cord problem? or is this a lower motor neuron problem in the roots plexus or nerves? And we'll need to learn more in the history and exam to sort that out if we are even correct that we're on the motor side of the equation here. And then once we've thought about the broad brushstrokes of localization, we have to think about other aspects that we have here. And the other key one, as Suresh said, is time course, right? In all of medicine, the time course is really going to help us determine the differential diagnosis. So if we had heard that this was sudden onset, right-hand focal motor impairment, what would have jumped to mind, Nitya and Suresh? If we heard this was sudden, the patient woke up and suddenly had this.
I would first think of like stroke, obviously like stroke in the premotor.
Yeah, you think of stroke, right?
Yeah.
And if this had happened maybe over a couple of days, the hand was getting weaker over a few days, what might you think about there as far as just general etiologies?
I would also think of this like neuropathy or like cervical radiculopathies could, you know, I guess sort of cause that over 2 days. I think you could see that, and like any sort of infectious etiology that's like really broad. You can't really. I don't think so. You can get a very specific sign due to that, but any other.
Similar to what someone said.
Yeah.
Sorry, Suresh, I feel like I cut you off. Go on.
No, sure. You can.
I was thinking ischemia, like if there's a clot, if there's an issue in blood supply, it's I mean, it's kind of similar to what you said about the stroke. I think someone else had a great suggestion about a space occupying lesion. So those are definitely possibilities.
Yeah, so suddenly we would think of stroke. Stroke usually, you know, ischemia, blood supply issues, or hemorrhage. Usually the problem's going to emerge and evolve pretty quickly, seconds, minutes. Days, we might think about things like infection, maybe an abscess could present like this. Again, just the hand, as you said, Suresh, a little hard to imagine because the fibers for the arm, leg, face are close together. But maybe an epidural abscess in the spine could start this way. A demyelinating lesion, depending on the age of the patient, right, in the spinal cord or brain, could emerge and evolve over days. Other inflammatory things, if we heard both hands or both legs, maybe over days, we'd be thinking about things like Guillain-Barré syndrome, Guillain-Barré, we learned from one of our French-Canadian participants is the true pronunciation. I still can't change it around in my mind, but Guillain-Barré. And but just the hand as the presentation would be very, very odd for that. But in space occupying lesions over days would probably be a little bit unlikely, but over months, sure, for a malignant tumor, and over years for maybe a benign tumor like a meningioma. But what do we do with this years piece? If the hand has been getting worse over years, what sorts of differential diagnoses might you think of?
Like he's been having the same, like he or she has been having since 3 years. Like I would be questioning what prompted them to come right now, like why now? So what could be that sort of exacerbation of the symptoms, or is it sort of an acute and chronic presentation, or is it like there's something underlying, something is going on, and this is just the tip of the iceberg, the presentation? So would consider that as well. And I would also ask some common questions like, is he or she able to unbutton or button their t-shirts, or like, and then is there any change in handwriting and stuff like that? This is a common question, just to, you know, get more information about the motor impairment.
Yeah, great question. When you said handwriting, it made me think of something. Why were you asking about the handwriting in particular?
Like, as you said, like it's fine. I think the fine handwriting is like a more of a very like an advanced skill, I suppose, and this is like fine motor skills are like
Yes,
advanced motor skills in primates. So I thought of that.
yeah, great. All good thoughts. Yeah, go ahead, Nitya. Yeah.
Oh, I was also thinking that I'm wondering about their age, and if there's any accompanying cognitive impairments, because if they're a lot older and they have that fine motor impairment, I think the etiologies would look a little different, maybe. So that was just my.
And what would you be thinking of? I like the direction you're going here. Any diagnoses or categories of diagnoses in particular?
Just a second. I'm just thinking about it.
No problem. Let me ask you a question this way. Just in general, take the right hand out for a moment. Neurologic disease processes that emerge and evolve over years of time. What general category might you think about there?
If I'm thinking of cognitive impairment, I'm thinking like dementia, and I'm wondering if there's accompanying motor deficits associated with that. But if it was a younger person, maybe if there's trauma, I would think of more of trauma instead of degenerative changes.
Great. So I think keyword there, degenerative, right? So sometimes it helps if you say, gee, 3 years of right hand, what would do that? And say, well, 3 years of any neurology, what would do that? And you said, well, if this was cognitive, I would think dementia and I would think degenerative. Well, there you go, right? So what degenerative diseases then could affect the hand? So as you see, dementia, there can be some pyramidal or extrapyramidal signs. Well, Alzheimer's is just so common that rare, aspects of it can be present. But again, don't worry even now about fine motor impairment. Just think about degenerative conditions that could affect the hand. Anything come to mind? I'll give a, yeah, go ahead.
Oh no, I keep thinking about like myalgias, but usually those are more proximal. So I'm trying to think of like a distal affecting condition.
Here's a clue. Why did I smile when Suresh said handwriting? Is anyone picking up on my stream of consciousness here? Anyone boating alongside of me on my stream of consciousness?
Are you thinking about like a cerebral lesion, like the cortex?
I guess I'm thinking of sort of a buzzword for anyone who's a recent or soon to be USMLE step taker. If you heard somewhere in the vignette a mention of handwriting, what would jump out? Because it may be an interesting way of thinking about this case.
Yeah, like a lesion in the parietal cortex. There's this syndrome, I forgot the name, but you get agraphia, acalculia, and
Gerstmann syndrome, right? Then the
yeah.
patient might not be able to, I always forget if it's alexia or agraphia. It might be, I can never remember which is which, but, or which one is part of that. Visual finger agnosia and right-left confusion, right? Okay, that's one way of thinking about it. Anyone else?
Cerebellar ataxia.
So ataxia could affect the handwriting, tremors could affect the handwriting. So I guess I'll stop playing guess what I'm thinking. That's not my usual style, but if the handwriting was getting smaller and smaller, does that ring any bells for anyone? Deborah's handwriting is getting bigger and bigger in the teaching points. What is it?
Parkinson's, if it's
yeah, very good. So what if this fine motor impairment is bradykinesia, right? What if this is bradykinesia? The tremor of Parkinson's disease is a rest tremor, right? And so it shouldn't, in principle, especially in early stages, be affecting the fine motor skills. But if there's bradykinesia or rigidity, that could affect the movement. So that's another way of thinking about motor impairment that I hadn't thought about until Suresh mentioned the handwriting, and then I thought of micrographia, which is a sign of Parkinson's disease. And also thinking about that, right, because we said this 3-year time course, we're thinking of something probably degenerative. You could have maybe a benign tumor like a meningioma in a very strategic spot, pushing on the hand area of the cortex or some part of the spine. But degenerative conditions affecting the hand, right, could be Parkinson's disease. And then ALS is a pure motor degenerative syndrome. Just the hand for 3 years would probably be pretty atypical. Usually once ALS gets started, it's very progressive, but it starts somewhere, and it often, even though it's degenerative and presumably affecting the whole motor system, often starts in one limb. Staying in that limb for 3 years, be a little atypical for that diagnosis, but just something we could think about in this time course. Great. So yeah, another thought, Nitya, go ahead.
Just wondering, would osteoarthritis be possible? Because if this person is like a carpenter or someone who uses their hands a lot, over time, it could also be like a bone issue and not a neurological issue.
Right. So degenerative bone issues, right? So if there was cervical spondylosis, wear and tear arthritis of the spine, right? And that was compressing one or more motor roots, sort of C8, T1 roots, could impair hand function quite a bit. Carpal tunnel syndrome, right? Coming back to your initial hypothesis, Nitya, that this could just be something in the nerves, right? From repetitive use or from arthritis of the hand or many conditions that can predispose to that. You would get fine motor impairment because of, mostly in carpal tunnel syndrome, sensory loss and difficulty abducting the thumb. Sorry, I did adduction, but I meant to do abduction as I was saying it. All right, so we've spent a lot of time teasing this apart, and why would we spend so much time, right, drawing this out? Shema might be wondering if we'll have time for the history exam and the rest of her aliquots, but this gives us some sort of broader map and some potential routes through that map, right, to think about. And as we now start hearing the history, if the age, right, we've mentioned a few things that depending on the age, things will go up or down, whether there's sensory problems or not, things will go up and down, whether there's tremor or not, or cognitive feature. So many of the things we talked about that if they're there will influence our differential diagnosis. Now we get to find out whether they're there or not and start to see which path we want to take through this map of motor versus sensory versus cerebellar versus bradykinesia, rigidity, Parkinsonism in terms of the initial localization route, and then associated features to help us figure that out as well. And then other elements of perhaps other features beyond this motor impairment that might give us a clue to what might have been happening over these past 3 years. Great. So can we hear more about the history, Shema? Thank you.
Sure. It was an awesome discussion. So I will give you now more information. So the HPI, we have a 69-year-old female with worsening fine motor impairment of the right hand, like she has difficulties in dressing, eating, using the computer mouse. She used to work a lot with the computer, and now she says she has problems with it. And she also says that she has a decline in short-term memory, which becomes worse in stressful situations. And she also has trouble in finding words, and all these symptoms for 3 years. And the patient notes these symptoms started several months after her sister was in a severe car accident, which temporarily impaired her ability to move her arms. No recent infection, no fever, and she says that she had a weight loss of 8 kilograms within 2 months due to her gluten-free and vegan diet. And to the past medical history, she had a tonsillectomy 40 years ago, no allergies. She doesn't take any permanent medications. Her mother has diabetes type 1. Her father has hypertension. To the social history, she doesn't drink alcohol since 8 months. She used to drink alcohol occasionally, like 1 to 2 glasses of wine on a daily basis, but otherwise she doesn't take any illicit drugs, and she lives together with her husband and has a daughter. And her vitals are stable, and I would stop here before coming to the physical examination.
Perfect. Excellent, Shema. Thank you. Lots of interesting information here, as always. I think you're up first this time, Suresh. So I think I'll have you talk about this aspect, and then Nitya, I'll have you talk about the physical exam when we hear about that. What are your thoughts at this stage, Suresh?
Lot of information, but yeah, one thing that caught my eye was like the weight loss and the vegan diet. I don't know, like preparing for step 1 has made me think of, vegan diet, B12 deficiencies, and then due to that, and short-term memory or decline in short-term memory, that again, again points to some neurodegenerative disorder, as you alluded to before, Parkinson's and stuff like that. And I don't know if I can associate anything with her sister being in an accident before. Could that affect, and could this go down the psychiatric disorder lane or something? that I would also be considering all that. And I really don't know, like I don't have a direction to think about, because there are many different parts of this thing, and I can't sort of put them together. I would love to hear more on this. And
yeah, fantastic thought, Suresh. You're right. We want to try to use Occam's razor, right, and try to figure out how everything could fit into one potential diagnosis. But sometimes, as people like to say, we use Hickham's dictum, which is a patient can have as many diseases as they pleases, right? Or I'm not sure if that's the appropriate, if that's the true way Hickam said it, but that's how it's been conveyed to me. So I think it's reasonable as a first pass, right, to say what could explain all of this, and if we can't do that, to see what could explain some of it, right, and if the other stuff could be part of it, or we have to invoke two things. And I've talked about this before in our morning reports together, that sometimes it's a powerful strategy when there's so many different moving parts and there's something that doesn't fit, to just take that part out and see what makes sense for the rest, and then see if there's a way to link the other piece, or maybe the other link doesn't have an explanation related to the main underlying process. So, and another thing you did, I think that was great, Suresh, is you said, well, when I hear about gluten-free diet, vegan diet, I can't help but think about B12 deficiency. And some people might say, no, first take the history and then decide. But I think you're exactly right. You say this patient's at risk for B12 deficiency. Can any or all of this be explained by B12 deficiency? So B12 deficiency can certainly cause cognitive symptoms and neuropsychiatric symptoms. So could some of that short-term memory loss or word finding be actually an effect of B12 deficiency? And then B12 deficiency can cause a peripheral neuropathy. Usually that's going to be a limb-dependent symmetric neuropathy. So just the hand for 3 years wouldn't quite make sense there. And it can cause subacute combined degeneration, which is a myelopathy plus a neuropathy. So you'd get both, and it can cause myelopathy, neuropathy, and cognitive symptoms all at once. Although still, to get just the right hand for a systemic metabolic problem would be a little atypical. But that certainly my antenna went up for that piece as well. I follow a vegan diet for what it's worth. I've tried to figure out, can you get B12 in a natural vegan diet? It's extremely difficult, and from what I've read, even pretty hardcore vegan folks take a B12 supplement. It's just very hard to get it from a plant-based diet. So I'm glad you picked up on that, but I think you sort of picked up on the key conundrum here, Suresh, which was how, if in any way, does all of this fit together? And I don't have a clear answer for that at this stage as well. If you heard just 69-year-old woman with progressive short-term memory loss, I mean, what diagnosis would you be thinking of?
I had another thought, like
please,
it's mentioned decline in short-term memory, which worsens in stressful situations, that I thought of transient global amnesia with, under stressful condition, they have this anterograde amnesia for like around 12 hours or something. So that's episodic as well. So maybe that could be, I don't know.
Yeah, good thought. Yeah, so transient global amnesia is not too common, but common enough that a neurologist in a busy practice will see it a few times a year. Usually in that case, it's a discrete event. Very rarely it can recur, but usually the story is that the patient has been under some acute emotional event, which can be a stressful event, an accident. It can be jumping into cold water. It can be sexual intercourse, anything that has a high emotional valence. And then the patient develops anterograde amnesia. And so keeps asking the same questions. Where am I? How did I get here? As soon as the short-term memory buffer expires, they go out again. It lasts usually the better part of a day and then resolves. No one knows what causes it. Sometimes on MRI, there's a little punctate area of diffusion restriction in the hippocampus, one or both, suggesting that something vascular happened there, but patients usually recover. And it is a syndrome, so it can be caused by infarcts in the medial temporal lobe or the anterior thalamus, but usually it's just something that happens. We don't have a great explanation for it, but that shouldn't be progressive. That's usually sort of one event, but I'm glad you invoked it because we're consulted for it a lot, and it suggests to me that it's something only neurologists know about, because for us, it's so obvious when we see it, and most people are wondering, was it a stroke or what happened here? But sort of progressive short-term memory loss and isolation, we might think about Alzheimer's disease, and word finding difficulty can be part of that. And you mentioned, could this be a psychological or psychiatric condition given the precipitating stressor and sister's accident and the worsening of stressful situations? But gee, it must be pretty stressful to have a cognitive impairment, right? And so under stress, if your memory is already impaired, right, it might be feel even more impaired or be even more impaired. Those of you who are, depending where you are in training, staying up all night and then trying to present your patients in the morning, when your memory is impaired from sleep deprivation, right, as it gets more stressful, your memory might feel more impaired. So psychiatric or sort of stress-induced condition here, patients with severe anxiety or depression can report trouble in their short-term memory and word finding, because anxiety and depression are using a lot of the bandwidth of the mind, as I, sort of when I explain this to patients who've come to the neurologist, and we see that it's probably more likely a psychiatric condition causing neurologic symptoms, the bandwidth of the mind being used for the processing of anxiety or depression can diminish attention to the outside world, as so much attention is focused on the inner world. And that can lead to decreased memory, difficulty finding words, because attention with what's happening outside is impaired by all of the attention being focused on what's happening inside, is sort of one metaphorical way of sometimes explaining this to patients. But none of that would explain what's going on with the right hand, right? So could this be some very slow growing lesion on the left side of the brain that is affecting the right, maybe side of the body, but the hand is more obvious to the patient because it's used in all of these fine activities, and also affecting language areas on that left side? Or some slow growing frontal lesion that's impairing attention, and the patient perceives that as memory loss or word finding difficulty, when attention is sort of the cognitive lesion. One of my professors used to like to say, it's like those wooden dolls where you open the doll and then there's another doll inside and there's another doll inside. That attention is the first doll. And if you can't pay attention, right, you can't form a memory. And if you can't form a memory, you can't really have meaningful language. I think of it sort of like successive doors to the inner, sanctum of the mind, right? So if you're, listening to a lecture, but actually you're, typing on your phone, and then the professor points at you and says, answer this question, you realize it's not your memory, right? You weren't paying attention, so you didn't put it in memory. So could this all be attentional from some sort of frontal lesion or some other process? But we'd have trouble explaining that hand. And we haven't heard anything here to really push us to the Parkinson's side, right? We haven't heard about a tremor, although some patients present with predominant rigidity and bradykinesia in Parkinson's without much tremor. And you can have cognitive symptoms early in Parkinson's disease. They're usually more sort of executive visuospatial than memory per se. So that's a long way of saying I agree with you, Suresh. I don't have a clear way of putting all this together or deciding what streams to go along separately. So I think the exam is going to be very helpful in terms of really figuring out what the cognitive lesion is. Is it, if the attention is intact, patient can count backwards serial sevens, can say that months of the year backwards, but memory is impaired. That's helpful. If the attention is impaired, it's hard to kind of, the first doll is not there to open, so it's hard to assess memory. And then what's going on in that hand, right? Which muscles are weak? Is there upper motor neuron signs or there lower motor neuron signs? All things that I think the exam will help us figure out. And are there signs beyond that arm and hand, right? Is there something going on in the leg on that side too? Some hyperreflexia, Babinski sign, things that would show us, are we peripheral or central? Or does this patient have two completely separate conditions, a neurodegenerative condition affecting the mind and carpal tunnel syndrome in the hand from all of this working a lot with computers, right? And these are just two totally separate common problems that are so common that a patient might be unfortunate enough to have run into both of them. All possibilities and all fair game. And I think the exam is going to be very elucidating for us here. So I'll have you discuss the exam, Nitya, after we hear more about it from Shema. So tell us what you found, Shema. And also, I guess, let me ask you on the history, no sensory, no bowel or bladder. What we see is what we get here. Anything else that we missed on the history? No sensory problems, no problems in the left hand, no problems in the legs, no problems walking?
No.
Okay, great.
Good.
So what did you find on the exam?
So to the mental status, so she is alert and oriented, no hallucinations or delusions. The mock-up test was normal. She had quite some difficulties in drawing and in word generation, but she didn't have any problems in repeating sentences or naming things. If I show her like something, this, what is this? And to the cranial nerves, what we discovered, she had hypometric antisaccades. And in motor, there was an ideomotor apraxia. So we performed a Luria test. As you know, it's a test with fist, edge, palm, like repetitive movements to do this. And she had difficulties doing that, and also a micrography. And to the reflexes, she had increased right-sided biceps reflex and increased adductor and knee jerk reflex with elevated reflex zones bilaterally. And there was a right-sided rigidity and cogwheel phenomenon in the upper extremity and lower extremity during distraction. And to the sensory, we only discovered a right-sided cortical sensory deficit, so a graphesthesia. And to the cerebellar, there was a right-sided dis and bradydiadochokinesia, and in the upper extremity, and there was a dysmetric finger-to-finger and finger-to-nose test. The Romberg test was negative, and she didn't have any sleeping disorders. Stool and micturition were without any problem. Yeah. So in sum, summing up her physical examination, she had a hypokinetic rigid syndrome, mostly of the right upper than the right lower extremities, with ideomotor apraxia, cortical sensory deficit, and hypometric antisaccades. Yeah.
Fantastic. That is a lot of information. Let me just ask you, since you've put this together, and so we can help Nitya think through this and help me think through it. Can you explain what a hypometric antisaccade is?
So basically, and when we know saccades is actually rapid eye movements, and like if I show my fingers, I'm telling the patient, look at the finger which is not showing the stimulus. Like this is the stimulus, but we have to look at the one which isn't showing the stimulus, and it's basically to test the I would say the executive function of the brain. Yeah, and there we differentiate between hypometric antisaccades and hypometric. And I read like if we have hypermetric, it's usually something like a cerebellar disorder, and if it's hypometric, oh no, I don't want to tell it. Otherwise,
it's complicated. But yeah, big picture, eye movements. You have smooth pursuit, which is when you follow a moving object. And if you try this in the mirror, you can't have smooth pursuit without an object to follow. You'll have saccadic movements, and a saccade is a quick movement. So as Shema beautifully described, to test a patient's saccades, you have them look at your nose and say, either look at the finger that moves, or I'll say nose, finger, nose, finger, nose, finger, nose, finger, right? And the patient is making saccades. And then antisaccade is a little more complicated. You're telling them look in the opposite direction. Okay, so Nitya, there is a lot of stuff here, and there's a lot of very advanced, what I call gourmet neurology. After one of my attendings, he used to call these things gourmet. Feel free to pick out something in here that you can work with, or the whole gestalt of things, or different pieces of it, however you'd like to approach it.
Of course, yeah, this is really exciting. So for the saccades, like cranial nerves 3, 4, and 6, I'm thinking of possible deficits there. I thought it was also really interesting to see the reflexes, because, you know, for biceps, we're thinking like C5, we're thinking like for the knee jerk, we're thinking C4, and then the rigidity. So we're seeing like hypertonicity, and the finger and finger to nose test, and dysmetria, and bradydiadochokinesia, like those, like, you know, cerebellar issues. The Romberg being negative is kind of different, because I would have thought that it would be positive. And it's interesting that, like, even though we've talked about how there's an attention deficit and some memory issues, like the MoCA test was normal. There's no hallucinations or delusions. And so it's it seems to be like a very localized lesion because there's difficulty with drawing and word generation, but repeating sentences and naming things, like the hippocampus doesn't seem to be involved.
Yeah, great thoughts. So let's take some of these things in pieces. You made an important point. The patient is expressing that there is a cognitive disorder, and we're seeing cognitive abnormalities. And the MoCA, some people use the mini mental status exam, but the MoCA is a little more sensitive for certain executive aspects. And you can also get the MoCA in any language. You just select the language or almost any language. So that's helpful too. And there's multiple versions, so you're not always doing the same one for the patient. And it shows that, you know, sometimes patients have cognitive deficits that are not captured by this. And if you think about it, all people on this call, right, have taken very complex exams and learned complex things, right? And it would take not much of an impairment, right, for us to feel like I'm not doing complicated things as well as I should, but yeah, I can count backwards by 7. Thank you very much. You know, I can remember 3 words. Thank you very much. But I'm having trouble doing statistical modeling or, you know, teaching physics or, you know, driving a car or something that's a little more complicated than a MoCA. Great. So there's cognitive deficits here, but we didn't really maybe get to the bottom of them through the tools that we have, except to know that there's something going on there. And then you mentioned the reflexes, Nitya, that they're hyperreflexic. What does that tell you just in general, that the reflexes are brisk?
I'm thinking that the impulses are more active than we would expect. So I'm just trying to think back to like etiologies for hyperreflexia versus hyporeflexia.
Yeah. So hyperreflexia is sort of a disinhibition. As you said, there's too much motor, and so that suggests an upper motor neuron problem, and so things are sort of disinhibited in that spinal cord. So that tells us we're in the central nervous system, which is one of the first questions we were wondering about. So there's a lot here. You found cerebellar signs, you found upper motor neuron signs, you found rigidity, you found cognitive signs, you found problems with saccades, lots of things going on here. So do you think we could localize this to one place in the brain? For example, if you got a scan, would you be thinking there would be one lesion in one place that all roads lead to this place? Or do you think we're concerned about a multi-system disorder here?
Other than the weight loss, there doesn't seem to be like many systemic issues. I do think that this is mostly localized, especially because really specific functions were taken away, and not general functions in like depending on areas of the brain. So that's my thought process.
Yeah, great. I should have clarified. As a neurologist, when I say multi-systems, I only mean systems within the nervous system, because I don't, of course, I do think about the other body systems, but not as an internist to it. So yeah, so that was my fault for asking a neurospecific, a neurocentric worldview type question. Do you think within the nervous system, remember we began asking, hey, is this a motor problem, a sensory problem, a cerebellar problem, or a sort of higher level Parkinsonian motor control problem? Do you think we could localize this to one of those systems, or do we have to invoke sort of multiple neurologic symptoms, acknowledging, as you said, that the kidneys and other transplantable organs are working okay?
So if I'm looking at neurology, I'm thinking that it's multi-systemic.
Yes. Yeah, exactly right. We have corticospinal findings, pyramidal findings. We have findings of Parkinsonism, which is some type of basal ganglionic finding. We have cortical sensory deficits that the patient can feel, right? That Shema was tracing on the hand, but couldn't say if it's a 4 or a 5. So that's a very higher level cortical sensory parietal function. Apraxia, we would get hours going down that rabbit hole. It's very hard to understand, but is some higher level motor, right? The patient may have full strength, coordination, and sensation, but can't kind of do the right sequence of actions. And this LORIA test can be interpreted in different ways. It's generally considered a frontal type of test of sequencing motor actions, and usually do it with the patient fist chop slap, I guess you can say, or just show it and the patient does it and then they sort of lose track of that sequence of movements. So again, just generally sort of frontal, right? So we have multiple systems involved within the nervous system, most of them higher level, right, in the skull somewhere. And we have that happening over years. So any sense of what type of diagnosis we might be thinking about here, Nitya or Suresh? And going along with that, what tests, if any, might you order to try to sort this out?
Like there are like many symptoms are present. So like the cogwheel phenomena and the prior symptoms directed us to Parkinsonism, and the other symptom, like I'm trying to integrate all of them at the same time, trying to considering them individually. I'm thinking of Parkinson plus syndromes with spinal muscle atrophy and stuff like that could explain the upper motor neuron findings. And the cerebellar signs, I'm not able to integrate the cerebellar signs and
Great. So let me pick up on one thread here. You said the term Parkinson's plus, Suresh. Can you explain to our friends here what you mean by that?
Parkinson plus syndrome, like you have the features of Parkinsonism along with another sort of another disorder, like you have spinal motor atrophy, then polymotor. I don't remember. I just read it long time ago. And
no problem. Yeah, it's a very important thought in this case, though. And you're on the right track. Let me just ask Nitya, and then I can explain. Are you familiar with this term Parkinson's plus or atypical Parkinsonism?
Yeah, what I understand from it is just that there are some Parkinsonian symptoms associated with like another diagnosis that like all the other symptoms seem to fit that diagnosis, but we also have Parkinsonian symptoms. And in this case, like similar to Suresh, I definitely see that there are some Parkinsonian symptoms, and it seems to be like a multiple sort of issue. So an MRI would be really helpful, and we'd be able to see like if there are inclusions that indicate an MSA or another neurological issue.
Yeah, good for you for knowing about MSA or rare condition. Do you know any other names of any other Parkinson's plus or atypical Parkinsonism syndromes? And then I can fill in the gaps here. So MSA is one. We'll talk more about that in a second. Do you know any of the other ones?
I'm unaware at the moment. I can definitely look them up.
Worries.
Feel free to fill us in.
They are not common, and I certainly did not know any of them as a second year med student. So you're ahead of the game for sure. So Parkinson's disease is very common, idiopathic, usually genetic, rarely. And the syndrome, right, is bradykinesia, rigidity, and arresting tremor and postural instability. Usually starts off, unlike many degenerative diseases, very asymmetrically in one limb, and then becomes bilateral over time, but usually stays asymmetric. And it's very common. I forget the numbers, but something like 1% of people over 70 or something like that. Don't quote me on that, but it's very common. Parkinson's disease, but those features of Parkinsonism, right, of bradykinesia, rigidity, and resting tremor, have a differential diagnosis. Broadly, that is divided into degenerative causes, of which Parkinson's is one example, and secondary causes. And those secondary causes can include drug-induced Parkinsonism from antipsychotic medications, antiemetics, manganese toxicity, poisoning is another one, and MPTP, which was a synthetic opioid, I believe. There was sort of an outbreak, if you will, of Parkinsonism amongst people using this synthetic illicit drug. And then on the degenerative side, the pie chart is mostly Parkinson's disease, but then there's these other atypical, sometimes called atypical Parkinsonism. I think that's the modern name, but Parkinson's plus is another term that I use and hear as well. And so these are conditions, as Nitya and Suresh said, that Parkinsonism is part of it, but it's not Parkinson's disease. These are degenerative conditions, and they each kind of have their own signature. So one that most people are probably familiar with is dementia with Lewy bodies, right? This is Parkinsonism, hallucinations and fluctuations, and dementia syndrome, usually with executive dysfunction and visuospatial dysfunction, as opposed to memory impairment, as in Alzheimer's, probably the second most common degenerative cause of dementia. So there's Parkinsonism, but it's not Parkinson's disease. And then very uncommon are three conditions. One is multiple systems atrophy, as Nitya said. And the sort of hallmark there is autonomic dysfunction. You can get some autonomic dysfunction in Parkinson's disease, but here profound orthostasis, erectile dysfunction in men, bladder dysfunction, et cetera. And there's MSAP, which is MSA Parkinsonism, and MSAC, which is MSA cerebellar. So we don't hear about any autonomic things here, but MSA, we talk about MSAP and MSAC, but patients can have both. So that's MSA. Another one is PSP, progressive supranuclear palsy. The hallmark there is a vertical gaze palsy and early falls. Patients with Parkinson's actually don't fall till relatively late in the disease. And they tend to fall forward because they have this stooped gait and these small steps, and they kind of get accelerating and fall forward. Excuse me. And patients with PSP tend to fall backwards because the postural stability from the outset is very severe. And I remember a patient who I diagnosed with, who I think has this condition, it's hard to prove. Every time she sat up on the examining table, she just kept going backwards because the postural reflexes are impaired. And there's, if you examine a lot of older patients, you'll see many have some decreased up gaze. That's can be normal, but very specific is decreased down gaze or slowed vertical saccades. And then the last and probably most relevant one, but also least common, is called corticobasal syndrome. Terminology is very confusing because corticobasal degeneration refers to a pathologic subtype, which can underlie a number of actual syndromes, and corticobasal syndrome accounts for a clinical phenotype, which can have multiple types of underlying pathology, including corticobasal degeneration, but you can also get Alzheimer's and tau and other pathologies. And corticobasal syndrome can have lots of things, but the hallmark is that it's very asymmetrical, and there's often cortical signs going along with Parkinsonism in a very asymmetric fashion. So patient might have rigidity, tremor, bradykinesia in one arm, the other arm is fine, but in that same arm, they can have apraxia, so difficulty with complex learned actions. They can have something called the alien hand syndrome, which I've never seen, but have read about, where the hand is just doing very purposeful things, but not with the intention. So one of my colleagues said they once saw a patient buttoning their shirt with one hand and the other hand was coming back and unbuttoning it. So this patient has pyramidal and extrapyramidal signs and cognitive dysfunction, and it's all really involving that one side. So probably this is starting to look to me like corticobasal syndrome, which would be very hard to prove. So I agree, we've all agreed this is in the brain and we'd want an image and make sure we're not missing something we could treat, but the hallmark finding would be very asymmetric atrophy, usually of parietal cortex and ipsilateral basal ganglia. That's very asymmetric. So I had one case, I've lived in Los Angeles now for about 2.5 years. I've seen one patient with this who presented with a very progressive difficulty using her hand and was diagnosed with an anxiety disorder. Got worse with stress, there was an accident, and her MRI was read as normal, but if you look closely at it, one ventricle on one side was clearly bigger in the occipital horn, and that was because there was some selective atrophy there. And the patient for years had just had trouble with that hand. It was actually very sad. Within 6 months, the other hand became involved, and then she couldn't walk. And so it can progress very indolently and can also progress very rapidly. There's usually myoclonus on the affected side also, but when you see something so sort of multi-system, but continuing, multi-neurologic systems, but continuing to affect one limb with Parkinsonism as a feature, corticobasal syndrome is something to consider, but very uncommon. In a dozen years, maybe I've seen it 2 or 3 times. So probably an image, and that's what we'd be looking for. And we're getting down to the wire here, but I promise, Shema, I've tried to budget my time appropriately based on where I think we're going here, but you can, maybe I've steered us astray and want to quickly account for a lot of new information. So tell us what your team was thinking at this point, and if you were able to get some imaging or other aspects here that helped with the diagnosis.
So basically, what I also read in the chat, there was the hypothesis of a conversion disorder or any somatization disorder. This was also one of our hypotheses because the patient knows the symptoms started right after her sister's car accident. But then we performed the whole imaging stuff and so on, and something pathological came out. So firstly, to the labs, you were thinking about anything with vitamin deficiency. Her vitamin B12 was 908, folate acid was above 20, so there was no problems with her vitamins because she supplemented them. And to the imaging, her cerebrospinal fluid was normal. To the CMRI, there was a left-sided parietal atrophy. The MEPs, the muscle evolutional potentials, were normal. There was no difference of the amplitudes between the right and the left side. We also performed a sonography of the substantia nigra. There was no pathological echogenicity. We also performed a levodopa test. She didn't respond at all. And we performed a Shellong test, which was also normal. And we performed a sonography of the bladder. There was no pathological residual urine. So that's why we were like, if we exclude any autonomic involvement, this was like for us to exclude that this is something like MSA, because like during my internship there, I was told we differentiate these Parkinson plus syndromes between tauopathies and synucleinopathies. And tauopathies, this was also an assumption of like PSP and CBD was also an assumption. And tauopathies per definition don't cause any autonomic involvement, which wasn't present here. And now coming to the further imaging, her DET scan was initially normal, but the FDG PET scan came up pathological. The FDG PET revealed asymmetrical cerebral glucose metabolism with hypometabolism in the left parietal cortex and lesser in the left putamen. And with this information bias, it was concluded that there was a decrease of the receptor density in the left posterior putamen in the DET scan. So it was concluded that this is a cortico-basal degeneration. And as you solved very perfectly, because like for CBD, which is a tauopathy, it's very typical. We have this asymmetrical hemi-Parkinsonism, this alien limb phenomenon. I mean, I also asked her if she has something like, does your extremity sometimes feel strange? And she said it, but I didn't want to involve this in the HPI because this would have revealed too much. And also there was, as you can see, aphasia and also problems with executive functions like the pathological Luria test, and also the hypometric antisaccades. Like hypometric antisaccades are very typical for neurodegenerative disorders. Yeah.
Wow. One quick question. I'm not familiar with the Shillong test. What is that?
Shellong. Oh, and maybe, I don't know whether this term is, okay, in Germany we say Shellong test. It's basically to see whether there is orthostatic hypotension. Like we measure the blood pressure and the
in the different positions.
Yes.
Oh, I didn't know it had an eponym. Everything has an. I thought, wow, that I've never even heard of that test. You're light years ahead of us there in Berlin. But okay, just a good old blood pressure cuff test. So really brilliant presentation, Shema. And I think in these conditions, the clinical picture is usually the most helpful, and the rest we're sort of just trying to make sure we're not missing something we can treat. So just a couple of little points here. I know there's a lot of information there. We want to give Maria time to talk about some teaching points, but the MRI findings here can be subtle, but as I mentioned, in the case I thought even a scan was read as normal, but seeing focal atrophy is in line with this corticobasal syndrome. And then you mentioned the levodopa. So levodopa, carbidopa, Sinemet is a trade name, is a treatment for Parkinson's. And actually the diagnostic criteria for Parkinson's, you need to respond to carbidopa, levodopa, and patients will respond sometimes dramatically. Unfortunately, in the Parkinson's plus syndromes, Lewy body dementia, multiple systems atrophy, progressive supranuclear palsy, and corticobasal syndrome, there's usually minimal, if any, response. We always try it. If the Parkinsonism is disabling, if the patient can get some maybe relief from that part of it, since the other symptoms are not treatable, but very characteristic of these conditions is that they don't really respond. And then if you want to try to get as close as you can to a diagnosis, for example, if there were a clinical trial in which to enroll this patient, or for prognosis, the DAT scan is a dopamine transporter scan, which can look at dopamine uptake. It doesn't distinguish between Parkinson's disease or Parkinson's plus. It just tells you there's a degenerative condition of the basal ganglia, but for example, could help you distinguish from a drug-induced Parkinsonism or something like that. And then PET is looking for areas of hypometabolism that can have particular signatures that associate with particular neurodegenerative diseases like temporoparietal and Alzheimer's, temporoparietal occipital, and Lewy body dementia, or in this case, very asymmetric parietal ganglionic or corticoganglionic, hence the name corticobasal syndrome. So the terminology keeps getting trickier with these. As you mentioned, Shema, we're thinking about them more in terms of the abnormal protein. Is it tau? Is it synuclein, et cetera? And so technically this is corticobasal syndrome, and we would only know based on pathology if this is corticobasal degeneration, which is describing what they see under the microscope, because Alzheimer's pathology can also cause corticobasal syndrome. And you might say, but we can't treat any of these anyway. But this is how we're going to learn what they are and how to recognize them. So thank you for bringing this case. And thank you, Suresh and Nitya, for your very wonderful discussion of a very complicated case at each element here. What a great way to celebrate the 600th VMR. I had no idea that was our milestone today. I feel like the ceiling should open and the balloons should fall out. For all us, maybe someone can make our Zoom screens do that. And for those of you who need to run, that's fine. Otherwise, Deborah, we'd love to hear your teaching points.
Hello, everyone. Yeah, it was really good. Shema has this case for a while. She was saving for today, so thank you. And yeah, talking about the teaching points, in this case, the time course is crucial. So we got to see if it's suddenly, if it's from days or year. When we think about this suddenly, we think about stroke, ischemia. If we think about days, we can think about neuropathy, infection, something inflammatory, or a meningioma. Or if it's like about a year, we can think ALS, spinal issue, or a Parkinson, multiple sclerosis, dementia. And we get the differential diagnosis of Gerstmann syndrome that could be acroculia, agoraphagia, and RL confusion and finger agnosia. And as this patient said that didn't eat gluten, was vegan, we think about B12 deficiency that can cause peripheral neuropathic, cognitive symptoms, and subacute cognitive degeneration. And as this case, we did the differential if it was localized or multisystemic, and we thought there was multisystemic that could be in the caudal spine or the corticosensory. And during the differential about Parkinson and Parkinson Plus, the Parkinson Plus, it's the Parkinson Plus a spinal motor atrophy. So we can have multisystemic atrophy, PSP, MSA, and cortical-based syndrome. So thank you, everyone. We see the next Tuesday, I guess, for the next neurology.
Yes, I'll be here next Tuesday. Thank you again, Shema. This is a very complicated case, but you presented it very clearly and allowed us to have a very interesting discussion. And Suresh and Nitya, great job discussing a very complicated neurology case and getting in the sphere of the diagnosis. The rest was gourmet, and you'll get there if you become neurologist, but most people have not even heard of this condition. You got very close. I threw in the chat one of the first cases I saw. Residents and I wrote it up as a clinical reasoning case. You already know the answer, but we try to disentangle this corticobasal syndrome versus corticobasal degeneration confusion and talk about some of the features of this condition that we saw in this particular patient. Thanks again, everyone. Have a wonderful day, and hope you'll join us again next week and invite your friends.